Everyone. It's a pleasure to be here today. My name is Dr. Viktoria Eleftheriadou, and I'm an associate professor and consultant dermatologist at Walsall Healthcare and the Royal Wolverhampton NHS Trust. The title of my talk today is an update on vitiligo.
Sorry, everybody. I think we lost sound there briefly. Alex, did it just cut out after the first slide?
Yes, it did, yeah.
Okay. Let me see if I can remedy that. Apologies, everyone. We will start that second slide again.
Vitiligo is the most common depigmentation disorder, which affects about 1% of the population worldwide. Figures as high as 8% have been recorded previously in other countries, such as India, which means that vitiligo is not a rare disorder. And in fact, over 70 million of people have vitiligo. About 50% of people with vitiligo present with the condition before the age of 20, and nearly 80% before the age of 30. Recently, the British Association of Dermatologists guidelines for the management of people with vitiligo have been updated, and are now published in the British Journal of Dermatology. The goal of the guideline was to provide up-to-date evidence-based recommendations for the management of vitiligo, and in particular address important clinical questions relating to management of vitiligo based on relevant literature and evidence. What set the BAD guidelines apart from the other clinical guidelines? BAD guidelines are renowned worldwide for their robust methodology. National Institute for Health and Care Excellence has accredited the process used by the BAD to produce clinical guidelines. NICE, for short, is an independent organization, part of the Department of Health and Social Care in England, that publishes guidelines and develops quality standards. NICE accreditation is highly regarded accreditation program, and it helped to raise standards in guidance production and improve the quality of information produced for health and social care decision makers. Let's have a look at the general management recommendation. Alongside undertaking full medical history, the guidelines stress the importance of assessing and monitoring quality of life and level of psychological distress of patients with vitiligo. This is something which we wanted to stress in particularly, bearing in mind the psychological impact of vitiligo on its patients. These guidelines provide detailed recommendations on how and how often patients with vitiligo should be monitored, and we recommend monitoring patients every 3 to 4 months. And if
Sorry, John, I don't know if it's just me, but I think the sound might have just cut off for a second there again.
Sorry, Alex, what was that, mate?
I think that the sound for me, at least, it's cut. So I think on this slide, I didn't manage to hear anything.
Okay, I'll just try to replay this slide. Sorry, everybody. Doing our best.
These guidelines provide detailed recommendations on how and how often patients with vitiligo should be monitored, and we recommend monitoring patients every 3 to 4 months. And if once you have started your treatment and you're reviewed again in 3 to 4 months, there is a treatment response even small, then this is usually an indication to continue treatment. In addition, some evidence exists that recent onset vitiligo lesions respond better to treatments such as topical tacrolimus and phototherapy. And therefore, early treatment of vitiligo, including hands and feet, might enhance the chance of success for repigmentation. And now to the general recommendations. Screen all patients for antithyroid antibodies and thyroid function. This is because studies have reported that the incidence of thyroid disease is up to 52% in patients with vitiligo, and 3 to 90% of patients with vitiligo have antithyroid antibodies. Patients with vitiligo are at increased risk of Graves' disease, Hashimoto thyroiditis, and thyroid cancer compared to general population. If there is a diagnostic challenge, patients should be referred to healthcare professional experienced in managing vitiligo, which usually is a dermatologist at secondary care. Consider measuring vitamin D level, especially in people who avoid the sun, because we all know that vitiligo patches can burn in the sun, and this is something which I have encountered a lot in my clinic. And of course, offer sunscreen with 4 or 5 UVA rating and factor 50 SPF to be applied on vitiligo patches and surrounding skin before going out into the sun. So how do we select the appropriate treatment for patients with vitiligo? In order to achieve repigmentation, which means getting your color back, first line usually is potent or very potent topical corticosteroids once daily. And however, this is recommended to be avoided on the face and especially periocular area. For facial vitiligo, as an alternative to topical corticosteroid, topical tacrolimus twice a day has been recommended. It is important to stress that all topical treatments need to continue for at least 3 months, providing there are no side effects, to see any initial response. And usually they have to continue for longer, up to 6 or 9 months or even longer. And for that reason, for areas with thinner skin, such as genitals and skin flexures, intermittent application of topical corticosteroids with topical calcineurin inhibitors such as tacrolimus have been recommended. So what would be the next step in the management of vitiligo if creams have not been successful or have not been effective enough? We recommend offering narrowband UVB, which is phototherapy, whether is a whole body or localized, combined with topical corticosteroids or with topical calcineurin inhibitor. And for rapidly progressive vitiligo, we are suggesting considering oral steroids with combination of narrowband UVB. So let's have a look at the first recommendation. Localized narrowband UVB is handheld phototherapy. An example of such device you can see on the picture here. If appropriate training is provided, patients can be taught to self-administer handheld phototherapy at home without the need to travel to the hospital. Interestingly, handheld phototherapy compared with excimer lamp have shown to be even slightly better, but not statistically significant, and in achieving over 75% of pigmentation. You might be aware that the most recent data from the Highlight trial has shown that handheld home phototherapy in combination with topical corticosteroids is better compared to topical corticosteroids alone, or better compared to light therapy alone. Almost 2/3 of people using both treatments in combination achieved at least partial treatment response in 9 months. Considering the newly emerging evidence that early treatment of vitiligo lesions seems to be more effective, home-based targeted phototherapy is a safe option if done under supervision of trained clinician. What to do in case if your vitiligo starts rapidly progressing, which means you develop new patches or existing patches extend in a matter of days or weeks. Then we recommend narrowband UVB should be started as soon as possible, combined with a very low dose of oral steroid, oral betamethasone in this case. This, of course, has to be done under the supervision of dermatologists at secondary care. And now to the third line treatments. These treatments are not widely available on the NHS, but they are available in a limited number of centres with a specialist interest. As a third line treatment for vitiligo, excimer laser or light should be considered in combination with topical calcineurin inhibitor. Interestingly, meta-analysis showed that narrowband UVB and excimer laser give very similar results. Another meta-analysis also showed that excimer laser and excimer lamp also gave very similar results. This means that all three treatments, narrowband UVB, excimer laser, and excimer light, combined with topical treatments, can be effective for treating vitiligo. However, we are unable to, we couldn't see much of a difference between all three treatments and say that laser, for example, is more effective than narrowband UVB. For stable segmental or non-segmental vitiligo that is unresponsive to other treatments, surgical interventions such as blister grafting or cell suspension could be considered. I'm not aware of any NHS hospitals which offer this treatment, and they might be available privately in limited number of centres. However, it is important to consider the high cost of these treatments, as well as a very high relapse rate, which means that if after successful surgical intervention you get the color back on your patch, then there is a 30 to 40% risk that you will lose the color again in this patch after treatment. And finally, removing remaining pigment in patients with widespread vitiligo who are also psychologically devastated by the disease should be considered. Various treatment modalities have been tried, with the most frequently used in the UK at least as being monobenzyl ether of hydroquinone. You are probably aware that there is a first FDA-approved treatment for repigmentation of vitiligo, which is available in the US within the last month or so. Unfortunately, this treatment is not available in Europe or in the UK at the moment. However, it's a very large step towards treatment in vitiligo. Topical ruxolitinib cream is being manufactured by Insight and is recommended for vitiligo in adults and in pediatric patients 12 years of age and older, and is actually licensed for this. And I would like to update you about a new vitiligo research clinic which I run. I see patients with vitiligo at New Cross Hospital, and I see pediatric patients with vitiligo at Walsall Hospital. What do we offer to our patients in my clinics? We are currently in the process of establishing home handheld phototherapy service where we are planning to train our patients to use these devices, and then so you can self-administer this effective treatment on your vitiligo patches at the comfort of your own home. We're also preparing to start interventional trials for vitiligo. Unfortunately, due to confidentiality issues, I'm unable to give more details, but please watch this space. There are very exciting things coming to the UK. And we also offer services of depigmentation with monobenzyl ether of hydroquinone 20%. And finally, we have whole body phototherapy units also available in our center. So if you are interested and would like to explore any of these options, please feel free to ask your GP or your dermatologist to send a referral to Walsall Hospital to my clinic. So to summarize, I have presented up-to-date guideline recommendations for the management of patients with vitiligo. There's a new updated patient information leaflet available on the BAD website. Please feel free to read this through. And also, if you're interested to get a referral to our vitiligo research clinic, I will be more than happy to see you. I would like to thank my co-authors and the BAD for their input into the development of these new vitiligo guidelines. And thank you all very much for listening.
Super. So big thanks to Viktoria for that first presentation. She also has a second one for us, which I will just load up for you now. Bear with me 1 second, and we will get right on with presentation number 2. Sorry about the sound issues that were briefly affecting the first one. I think I've worked out what I need to do now. So hopefully this will be a lot smoother.
Good afternoon. My name is Dr. Viktoria Eleftheriadou, and I'm an associate professor and consultant dermatologist at Walsall and New Cross hospitals. In my second talk, I will talk about research into vitiligo. Vitiligo is not a cosmetic disorder. A recent systematic review on psychological effects of vitiligo showed that prevalence of most psychosocial comorbidities in vitiligo patients was significantly higher versus healthy individuals. Vitiligo patients are severely affected by depression, anxiety, feeling of stigmatization, relationship difficulties, amongst other disorders. Factors associated with a significantly higher burden included female sex, visible or genital lesions, age less than 30, particularly adolescent, and greater body surface area involved. The results of this systematic review raised the urgency for strategies, including better treatment, counseling, and cognitive behavior strategies to improve overall quality of life and psychosocial health of patients. Previous studies suggested that in addition to individual therapeutic interventions, such as medical treatment, there's also need for community interventions aimed at dispelling myths and raising awareness of sources of support and treatment. The disease which causes white spots was recognized since ancient times. Descriptions of vitiligo are found in Indian ancient sacred books and in the Bible. Also, it is believed that vitiligo-like lesions were depicted in a Korean portrait painting of a Korean court scholar, which you can see here on the left. However, vitiligo was not differentiated from leprosy. Therefore, this confusion with leprosy is an important cause for social stigma attached to the white spots on the skin. Since ancient time, and unfortunately even today, men and women with white patches of the skin were not respected in society, were disqualified from marriage, or if white spots occurred during the marriage, it provided reason for divorce. Why do research into psychological interventions for vitiligo? Vitiligo, prior to certain partnership, was established and included patients, healthcare professionals, and researchers with interest in vitiligo. Almost 500 participants identified and voted for top 10 research areas for the treatment of vitiligo. And these top 10 research areas provide guidance for researchers and funding bodies to ensure that future research answers questions which are important both to clinicians and patients. You can see the final list here on this slide, the top 10 treatment uncertainties, and number 2 reads, how much do psychological interventions help people with vitiligo? Therefore, both patients, clinicians, and funding bodies do recognize and realize that psychological aspect of this disease is of paramount importance. Let's have a look how currently patients with vitiligo are managed. Recently updated British Association of Dermatologists guidelines for the management of vitiligo recommend several treatment options such as topical corticosteroids and topical calcineurin inhibitors, and combination of phototherapy with topicals. All of them have variable degree of success. However, the guidance also stress the importance of assessing and monitoring quality of life and level of psychological distress of patients with vitiligo. Currently, there's a great variability in access to psychological services on the NHS. High intensity of psychological interventions such as CBT may also be variable, not only by nature, but in accessibility from area to area. Possible outcomes for patients in need for psychological interventions are, some of them will be signposted to online resources, some of them are followed up and monitored, or receive antidepressants, or put on a waiting list for high intensity psychological interventions, such as CBT or similar. Therefore, bearing all this in mind, my colleague and I are currently working on psychological intervention for patients with vitiligo and moderate to severe psychological distress. We are looking into developing an intervention which will help both children and adults when they need it the most, and will be able to support them psychologically and teach them how to cope with vitiligo. This is the list of my co-investigators. And I would like to thank the Vitiligo Society for their support in this research application. So what about any new and emerging treatments in vitiligo? I was quite impressed that in the last few years, there was an increased research activity and interest from several pharmaceuticals with regards to trying to find treatment for vitiligo. For several years, vitiligo has been neglected and has been considered a low priority for research for any pharmaceutical as well as researchers in some cases. All this has changed, and now there are several major pharmaceuticals trying to investigate and conducting trials looking into management options for this distressing skin condition. This slide summarizes some of the clinical trials which are currently ongoing and or have just recently completed. As you can see, there are several investigating products. Many of them are JAK inhibitors, both topical and systemic. JAK inhibitors have shown very promising results in the trials conducted so far, and we are eagerly watching this space. Although several trials on vitiligo investigational products are currently ongoing or have been just recently conducted, I felt quite disappointed with the fact that unfortunately the UK was not selected to be a recruitment center, a recruitment country, where the majority of the trials been conducted in the States and in some other countries in Europe. And I'm really hopeful that this will soon change. I'm sure that you have all heard the recent very good news with regards to the fact that first FDA-approved treatment for repigmentation of vitiligo is available in the US. Insight announced that the US Food and Drug Administration has approved ruxolitinib cream for topical treatment of non-segmental vitiligo in both adults and pediatric population. Is the first approved treatment for repigmentation and vitiligo. All the previous treatments, as mentioned in the BAT guidelines, are currently being used off license for vitiligo. Unfortunately, we do not have ruxolitinib here in the UK or in Europe, in fact, but everyone is eagerly waiting, and we are hopeful that this cream will reach our patients as well. And I will conclude my presentation today with a reminder of the new vitiligo research clinic being set up for adults at New Cross Hospital and pediatric patients at Walsall Hospital. This is a new service and a unique clinic across West Midlands and England in general. The aim of the clinic is to offer to patients with vitiligo new interventional products, as well as a home handheld phototherapy service. I'm unable to release more details due to confidentiality agreement. However, do watch this space, and if you are interested, you can ask your GP to refer you directly to this clinic if you're willing to travel. I will be very happy to help and to meet you. To summarize, vitiligo is not a cosmetic disorder. It affects millions of people worldwide. It has a profound effect on patients' psyche and well-being. Patients would like more research into vitiligo, and in particular also in psychological treatments, in addition to medical management for both adults and children. New interventional and observational trials are on the way to the UK, and a new vitiligo research clinic has been set up in the West Midlands, offering both access to trials to vitiligo patients, as well as, of course, medical management available in the UK currently. Thank you very much for listening. If you have any questions, please feel free to get in touch. Have a lovely day.